revisional bariatric surgery is something I do an awful lot of, and there are ranges of revisions, the band removals to other procedures. I think, number one, you get a lot of questions as to what procedure. How I make the decision is as follows. I get an upper GI series and I make sure that there's no element of pseudoachalasia or esophageal dilatation. If there's tremendous damage to the esophagus from the previous band, then you have to think that sleeve may not be the best choice. And you may want a low pressured system, and that may be even in my hands where I have some reluctance about gastric bypass and I don't regard it as a gold standard, a reasonable choice. I also think it's important for patients to realize we've just completed a study that looks at the difference between band removal to sleeve and band removal to duodenal switch surgery, or modified a single anastomosis duodenal switch. And it shows that the band is a negative prognostic indicator for weight loss going to sleeve, but it's not for going to the modified duodenal switch. And that's because it has the intestinal component. So the knock on this operation is you're going from one gastric-only operation to another gastric-only operation. What I would say about gastric bypass is that it's a low-pressured system and there's not a significant amount of intestinal bypass. So we've actually had the best results going to the modified duodenal switch. A lot of patients are concerned that they don't want their intestine altered. And again, our preference in those patients has been sleeve if the anatomy is reasonable, because it gives us an option later on. As somebody that's done a lot of revisions for the last 15 years, the hardest cases for me to handle are the bypass patients that have regained weight. For those patients, we really don't have a great solution. What works is difficult, converting them, basically reconnecting the stomach to something like a duodenal switch. Then you can get some marginal results with banding, but the simple stuff like endoscopic suturing or even banding really doesn't work fantastically well. Redoing the bypass is, as somebody once said, doing the same experiment and expecting a different result is insanity. So you really need to go to more up procedure. Just moving your limbs distal, everybody who's done that experiment is sorry 5 years later. So there really isn't any great solution. So that's why I try to, move at least towards what I think is the gold standard for weight loss operation, towards the duodenal switch or operations that preserve the pyloric valve. Thank you.
Okay. Yes.
The extraction of bands and then conversion to other procedures is certainly an increasing.
Can I place it on this here?
Yeah, go right ahead. It's certainly an increasing issue confronting bariatric surgeons. It seems that the band extraction rate is greater than 5% a year, meaning that patients that are 7 to 10 years out, like this patient, have more than a 1 out of 2 or even 70% chance of having the band removed, either because of complications of the band or, as like in this case, complications followed by inadequate weight loss. What to do with these patients remains somewhat controversial. A lot of people prefer gastric bypass. A lot of people prefer two-stage. It's kind of been our practice modality to look at pylorus-sparing surgeries and kind of do a sleeve or a modified duodenal switch has become our practice standpoint. I find, having done bariatric surgery for a very lengthy period of time, that the hardest patient for me to deal with is the gastric bypass patient that regains weight. I also find that the fact that the goal of medical therapy for obesity is to kind of keep insulin levels
even, and gastric bypass causes, a very hyperinsulinemic, hypoglycemic reaction.